One thing I was going to do, because I thought we can just, if I could just share my screen, great. I'm just going to share with you, because Oliver asked me about vitamin D, and it seems to be causing a little bit of confusion with me as well as with other people. So I'll just go through this, and if you've got questions, let me know, and then I'll hand over to Fiona, who's going to talk about what we're doing with RUDY and XLH. So that's me. Those are my declarations. So I'll just go through what vitamin D is, why does it matter in XLH, and what's the relationship with burosumab. So vitamin D was the cause of rickets. And rickets is when children are born with bowed legs and lots of other problems. And XLH is a very rare cause. But this chap, Francis Gleason, figured out it wasn't because women were drinking too much alcohol. It was actually due to a nutritional deficiency, and it was nothing to do with the mother. It was actually the baby that was the sling with the baby. And then in 1918, Mellenby discovered that cod liver oil could treat it. And then in the States, they discovered UV could treat it. And that's why it was pictures of those kids with UV goggles shining at light. But vitamin D is not really a vitamin. It's just basically a chemical your body makes. And this is a bit complicated, but it will make sense later on. So you have like a type of fat in your skin that the sun with UV then changes into vitamin D. So your sun makes vitamin D from your skin, and then that gets activated. And as it gets activated, it just adds numbers. So it goes from boring vitamin D to 25 vitamin D, gets one number, and then 125 is the most active form. And when it's fully numbered up, it can do two things. It basically makes your stomach absorb as much calcium and phosphate from the food, and then it helps get that calcium into the bone, into the muscle. So that's how vitamin D is made, and that's how it works. And what happens is if you don't have enough vitamin D, then you have less calcium and phosphate coming from your gut into your stomach, and also you get soft bones and weak muscles, which uh, we know with people with XLH, that's how it happens, but this can also happen just because you don't get enough vitamin D. And we have very clear guidelines. They're not followed at all well, but everyone over 65, even if they haven't got XLH, should be given vitamin D supplements. People who've got no or low exposure to the skin, though to cover up for cultural reasons, or are housebound, or live indoors, and also people with darker skin. So if you've got very dark skin, it doesn't matter how hot it is outside, the sun is not strong enough to make your skin turn from that fat into vitamin D. And so that's the sort of people who get low vitamin D. You can get vitamin D from food, but it's really, really, really hard. So there is the Royal Express Society. They've got the vitamin D food rich chooser, but the doses are tiny. You have to, I think like 6 eggs a day or something. It's an enormous amount of food you have to take to do it. So we get vitamin D from supplements. So this is where it gets a bit geeky. We've got an animal version, which they take the oil from sheep and then irradiate it. And that's called D3 or cholecalciferol. And then you could do exactly the same to yeast, and that's called D2, ergocalciferol, but it doesn't seem to work as well as the D3. It does work, but it doesn't work as well. And those both come in at the vitamin D level, and then your body adds the numbers so it becomes active. Now, where the confusion is, these are supplements. I don't really mind these. These are drugs. So we can give you the fully numbered up version of vitamin D. And that is a drug, and that is quite tricky actually, because that is a very strong medicine that will can significantly change your calcium and your phosphate. And that's why I use it in XLH, because it would increase the amount of calcium and phosphate, mainly the phosphate we're interested in, to get into your system. So supplements you can get from Boots, drugs you need to get from the farm. Boots and other healthcare providers and other outlets are available. And drugs you get from your doctor. Okay, and they are not the same. Okay, they're different. So what's it got to do with XLH? Well, XLH is where you have too much FGF23. So imagine this is your blood, this is the bucket, and this is you passing urine. Okay, if you have too much FGF23, you just leak out loads and loads of phosphate. The phosphate's lower in the blood, bones get soft, they get these micro fractures or cracks, and they bend. The joints get worn very quickly, and you get premature osteoarthritis, and the muscles become stiff and weaker. And what we did for ages was very simple. We just gave you more activated vitamin D and phosphate to try and keep up with the higher phosphate loss. But when we do this, actually, we do increase your blood phosphate, but we actually make you lose even more phosphate from the kidney because we're literally pouring in more phosphate into a very leaky kidney. So it doesn't intuitively make sense. So then along comes burosumab, which actually removes the FGF23. It's an antibody and gets rid of the FGF23, and your bucket doesn't leak anymore. So you don't have the leak anymore. And you can, and it's really, really important that you mustn't, unless a consultant tells you, you must never, ever, ever mix up phosphate inactive vitamin D with burosumab. Because the burosumab by itself should be enough to fix your phosphate, and you must at least stop a week before starting the burosumab. Nothing bad will happen in that week. You might feel a little bit more stiff, but you must never take burosumab with the phosphate inactivated vitamin D, even if your doctor doesn't remind you. So, what do we have? Why are we talking about? That's quite easy. If you're on burosumab, you don't need vitamin D. Well, it's a little bit more complicated than that. If you don't have enough vitamin D, then your body naturally will try and fix the calcium. And it does that by increasing something called parathyroid hormone. That's why in some of your blood labels, it will say PTH and vitamin D. And you think, why are you measuring that? I'm only in the phosphate. If you're vitamin D deficient, your parathyroid hormone level will go up because it's interested in the calcium. It doesn't really care about the phosphate. We have phosphate from our diet easily. It's the calcium. And what that does, the increased parathyroid hormone just helps the calcium level normalize. But as a side effect, and this is really important, it makes your kidneys lose phosphate. And if your kidneys lose phosphate, it actually makes the burosumab less effective in some patients. So that's why in most centers, they are obsessed with making sure you're on the vitamin D supplements, but not the drugs. And that is really confusing. I wish they would call something else, oranges and lemons, or something completely different, but they're not. They're both called vitamin D. The supplement protects you from that parathyroid hormone excess. And that's why we're very keen that if you're on the burosumab, you're taking at least some vitamin D so you're replete. You don't have to take too much. 400 to 2000 is more than enough, and that's in line regulation. And you can talk with your local XLH team that might want to measure the level, maybe a little bit more, but that's really where we stand. So I've been through the vitamin D. I've been through the difference between the supplement and the drug. Super important. Never take the drug form vitamin D with burosumab unless you're under very specialist care. And then it's really important that you don't forget about the supplement because you don't want to be on the burosumab, and because like a 10 penny drug, the supplement is all you need. You just need 10p's worth, and the vitamin D is very cheap, but that can really reduce the effectiveness of the burosumab. And if you do take it, then you normalize vitamin D and you don't have any more problems with PTH spike. So there are two types of vitamin D. There's the drug, which is an old treatment for XLH and must be stopped at least a week before starting burosumab, as well as stopping the phosphate. And what we call, it's a silly name, we call it parent vitamin D or supplemental vitamin D. That's an over-the-counter, often sold as a food supplement, and if it's low, it can make the burosumab work less well. So it's super important that when your team give you blood forms, you get them done on time. And because the NHS is so terrible, you have to send the blood results to the patient. And what we find really easy, download it on the NHS app and then just send those images to your doctor. So that's all I was going to talk about vitamin D. I hope I've made it less complicated and you feel more informed. But I'm happy to go through anything again because there is quite a lot of technical information.
I think it's perfect, Kassim. Obviously, I'll sh share a little story, but obviously this came about because I've been on Borosmab for some time, and I had some routine blood tests in February, And then I immediately had a phone call from the pharmacy in London saying, you need to be taking vitamin D, that it's rock bottom, that you haven't got enough in your body. And then I felt fine, I guess. I was still under the illusion that I was feeling okay. So I went off and got my prescription. And then I happened to be joining a call with Kassim a few days later. And I said, Kas, why is it so important? Why did they just lose their mind of, I mean, not having enough vitamin D? And you basically said, well, you're essentially wasting a really expensive product, Borosumab, that's being given to us, and it's just not being very effective in my body at all. So
Well,
if you just simply up the vitamin D levels,
it's not wasting. It will still work, but it won't
yeah,
work as well as it could do. And it's such
yeah,
a shame. It's such a simple thing. Remember, take a vitamin D every day. Some people only take it during the winter months, but to be honest, our summers have been, well, last summer was brilliant. There's no problem there, but some of our summers have been awful. If it's too cloudy, there's no vitamin D coming through. So you have to be a bit careful.
I think it's good. So yeah, now you'll be pleased to hear that I'm back on a high dose at the moment.
And then you'll go on to a smaller dose, and then you
Yeah,
get to take it. And then in 3 years' time, we'll have the same conversation. So if your doctor puts you on a high dose, you can't then go on to nothing because then you'll become low again. You have
yeah.
to stay on some regular dose for the rest of your life. That is safe. It's a very low dose. It just means you don't become deficient. And when you become deficient, then the Borosumab could be less effective.
And the bit I guess I found particularly interesting was when you said about I was a bit concerned about the amount that was being prescribed. It was about something like 40,000 units
Yeah, yeah.
every week. And, I said, is it, their concerns on the quantity? Because it just felt like it was just it feels like it's so high. I mean, it's 40,000
Yeah.
times what you get over a supplementation.
Yeah. So that's really so everything is relative. So for us, a high dose will be 300,000. So we do
Right.
give some patients 300,000, or we give them 40,000 every day for a week. So we
Wow. Okay.
do that. So 40,000, you shouldn't be taking it every day, but every week, my maths is terrible. 40 divided by 7 is not a lot. You're not getting that much. So you're getting, what, five and a bit thousand a day, and you're only doing that for a bit. So it's not that much. The recommendation is you shouldn't go regularly above 2,000, and if you're loading, you shouldn't go regularly above 4,000 a day. And if you go to the Royal Osteoporosis Society, brilliant leaflet on vitamin D, and you can read all about it there.
Right.
Yep, Fiona, I'll forward the slides. Are you there?
Is that working? Everyone hear me all right? Hi,
What?
I'm Fiona Kirkham-Wilson, so I've just started working with Kassim, and I was just going to tell you a little bit about what I'm doing in advance. I'm really sorry if there's screaming. I've got a 6-month-old, and he's not enjoying going to bed. So that's what the screaming is. If anyone hears it, he is fine. So I'm a medical doctor. So as Kassim said, I'm a trainee rheumatologist, and I'm about 2.5 years away from being a consultant. I think it can be really confusing when you say you're a trainee. I am fully qualified, I'm just not a consultant yet. So I trained in London. I trained at Guy's, King's and St Thomas's. I don't know if any of you are under the London hospitals, but that's where I spent a very happy 6 years. And then I graduated in 2019 and I decided to move back to where I grew up in Hampshire. And I've been working there since. I spent some time at the University of Southampton trying to work out what I wanted to do in terms of my academic work. And then, very luckily for me, I was offered a PhD project with Professor Javaid's team in Oxford. So I've just started there at the end of my maternity leave. So I'm balancing a whole new world. And it's a 3-year contract. That's what I'll be around for. And hopefully, I'll get to know lots of you during that time. Next slide, please. So I'm going to be working on the RUDY study, and I think probably quite a few of you have interacted with the RUDY study over the years, but for anyone that hasn't, it would be really great if you could join. So what I'd like to do is identify people with the condition XLH, and to do that, coming to events like this, obviously most of you on here will have XLH or be looking after someone with XLH. And other than that, I will be going to clinics. So I think someone mentioned that they were under the team in Sheffield. I'll hopefully go to Sheffield and sit in on some clinics there. I'll be going around the UK to the various different specialist centres that look after people with XLH and eberizumab to help get people involved with RUDY. I'd also like to understand why sometimes it's really hard to complete the RUDY questionnaires. I think there are people that find that they, for example, maybe they don't feel they've got time, maybe they feel like the questionnaires are too long. Really try and understand what we can do to make it as easy as possible to fill in the RUDY questionnaires so that we can understand XLH better and make it as good an experience for everyone as possible in terms of using the drugs and managing the condition. Increase the questions. So I have some specific areas of interest. They're things I've worked in before. So something I'm really keen to do is look at the women's health aspects. So far on this call, someone's mentioned pregnancy, for example. I'd like to understand what the experience of pregnancy is like for people with XLH, in the hope that we can work together to understand what I can do to support people at that time. And another area I've worked in extensively is menopause and the change in female hormones. That's not to say I'm not interested in men. I very much am interested in the men too. But coming from the background I have, I've been involved with women's health before. And then obviously RUDY is a wonderful tool to understand the drug beruzumab and understand how it's changing quality of life. Not everyone, it sounds like, is benefiting from beruzumab. So part of my PhD work will be to unpick some of those findings and hopefully help in terms of the guidelines for who should and shouldn't be having beruzumab. Yeah, so those are the aims. And then who I would like to join. So everyone, if you're not involved with RUDY, please look it up. Please register. You've all experienced XLH. You've all got a condition that makes means that you're one of the people with a rare bone disease, and by being involved with RUDY, hopefully, as I say, we can work towards improving things for everybody. Specific areas, it would be really great to get some of the teenagers who are moving into adult care, because as Kassim's mentioned, it's different for children. They're having beruzumab more often. And as they move into adult care, some of them might never have experienced some of the symptoms of XLH because they've been on beruzumab so much longer. So capturing that in the data would be amazing. Anyone who's not on beruzumab and is about to start it, anyone who's on beruzumab but is about to pause it. If you're not on there, we can't capture that data. And the sort of trial data, obviously, trials are really, really controlled. They're not real world. So RUDY is an opportunity to capture real world data. And then anyone who's looking after anyone with XLH, so maybe you're a parent with a child with XLH, you might have XLH too. It would be wonderful if you were both on RUDY. Anyone who is supporting an older adult with XLH, anyone who's supporting a partner with XLH. If you're involved in RUDY, then it will help us understand how beruzumab is impacting the life of people who are looking after with people with XLH. So that's a really, really basic overview of what I would like to do. And that's because it's really early days, but I'll be coming along to these talks and sharing what I've been up to and hopefully be able to answer questions as I go. If anyone's got any questions, please feel free to ask. Otherwise, I look forward to meeting you and some of you. Hopefully, I'll meet some of you in person.
Thank you.
Thank you.
I think it's really great, and just welcome to the RUDY team and the project. And I think it's really exciting that Kassim's got someone that's sort of dedicated to the project, because this data collection has been going on for quite some time, and people might a few years ago might be thinking, well, it was all about collecting data to be able to get access to beruzumab, but actually, what I think we've now learned, what everyone sort of understands, is that there is so much that we still don't understand about XLH, and there are so many gaps in our understanding, and that, like what you've got there on the slide, there's gaps in our understanding of teenagers, older generations, and I guess non-symptomatic patients as well, and whether giving beruzumab to those patients has any effect in their future. And I think what also one of the most interesting things about RUDY is the fact that this is a reoccurring study. It's not just a one-time questionnaire. I think it's I think a lot of people might get a bit confused about, you do need to go back into the project and into the system and update any new fractures or dental incidents, changes in medication and weight, etc. So I think it's so key. And yeah, I guess the other thing is I can't wait to hear what comes out of your research and the time you spend with the team. So I think myself included in the community are probably very excited to see what's going to be produced over the next couple of years.
You've identified a barrier for me already beautifully, that it's hard to remember that you need to come back. So thank you. Number one, I'll write them down.
If I can add to that as well, it's Sally here. I'm not sure why I've come up as XLH UK very officially, but it's me. I think sort of 2 points to add for me from the point of view of someone with XLH. I've been doing RUDY for I think a good few years now, and I think I'd want to stress for anyone that's not doing it how easy it is to use. First of all, it's very self-explanatory and interactive and easy to do. And on your point about keeping it up as well, I've got the email reminders, so I've no idea when it's due, but I know I get my email every, I think, 6 months, and I go in and update everything. But I think also in my work life, I work for a company that is related to medical research and gathering evidence. And I think working there has also shown me the importance of just having things recorded. And one observation I've had from joining XLH UK and meeting everyone over the last few years is how much we get on with things with XLH, which is great on the one hand, but I think there's so much of our experiences that isn't quantified to an extent that we can do further research or it can benefit as evidence for medication, because we just kind of suck it up and do it, but we maybe don't talk enough about what's actually happening and how much does it impact us and what does it feel like. And when I complete RUDY, it does really capture a kind of 360 of everything that's going on. So I would, say anyone that's not doing it, it is really useful, but it is also very easy to use, I think, as well.